I will call this hearing to order. Good afternoon, everyone. Quorum is present, and without objection, the chair is authorized to declare a recess at any time. I want to welcome all the members and witnesses to today's hearing. I know that the members have participated in similar virtual hearings this year with the full committee, but I would like to remind participants of some of the items to ensure that we have a smooth and engaging presentation as possible. If you're experiencing any connectivity issues, please make sure to contact your staff or our designated technical support so those issues can be resolved. To ensure that members and participants today can have a robust engagement and dialogue, I ask that members participating remotely continue to remain visible on camera for the duration of your time in this hearing unless you experience connectivity issues or other technical problems that render the member unable to fully participate on camera. Today we'll be using a virtual timer to keep time. To keep that timer in your view, select grid or focus view, move your mouse over the second thumbnail from the right, click on the white circle, select lock participant, and from the list of participants, choose hearing timer, and this will keep the timer in your view at all times. We'll also remind you, frankly, if you're over your time, and we'll let you know where you are. When you recognize, you will need to unmute your microphone and pause for 2 or 3 seconds before speaking so that your words are completely captured on the live stream. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Does anyone have a question about the procedures for today's hearing? Well, hearing none, we'll proceed. I'll now recognize myself for an opening statement. Today's Oversight and Investigation Subcommittee hearing will examine the Department of Veterans Affairs medical supply chain. Today's our first Oversight and Investigation Subcommittee hearing of the 117th session, so I'd like to welcome all the members who have joined remotely, many of whom are new to this subcommittee. During the coming months, we will examine many important issues at the Department of Veterans Affairs. I think it's fair to say that Ranking Member Mann and I share the goal of a strong, nonpartisan oversight. Our veterans deserve nothing less than that. Today's hearing comes nearly 6 months following this subcommittee's last hearing on the same subject. I hope to hear how VA has evolved its pandemic response and moved forward on key modernization efforts. VA's medical supply chain buys and distributes billions of dollars of vital life-saving medical supplies needed for veteran medical care in the nation's largest integrated healthcare system. Unfortunately, VA's supply chain has long faced many serious problems. The GAO added VA to its high-risk list for acquisition in 2019, largely due to medical supply chain problems. During September's hearing, we heard testimony that the weaknesses in VA's purchasing and inventory management systems were magnified by the pandemic. GAO testified then that VA's old systems could not provide daily supply inventory data. So VA had to create an ad hoc reporting process to understand how many supplies, such as masks and gloves, it had on hand. Fast forward 6 months to today, here we are 12 months into this pandemic, and VA is still largely using this manual spreadsheet-based system. It is important to acknowledge that the VA hospital staff and employees who have worked tirelessly over the last year to serve our veterans and procure needed supplies, they've done a terrific job. While heroic efforts have allowed VA to build its overall inventory of critical supplies in the last few months, I remain concerned about the unevenness of supply inventories and the continued rationing at VA medical centers. So, for example, the VA Inspector General issued 3 reports in the last 3 months that found examples of VA medical facilities around the country that either ran out of personal protective equipment or were running low and had to ration these supplies. Further, a March 2021 report found that up to 40% of staff at VA medical centers, quote, reported not having access to appropriate personal protective equipment necessary to ensure their own safety at work, unquote. I've personally witnessed pandemic supply challenges in my New Hampshire district. A state veterans home ran out of bleach cleaning wipes and reported trouble finding masks for its employees. Our Manchester VA Medical Center has continuously run low on nitrile gloves and N95 masks. My office even donated dozens of boxes to our local VA to help ease this supply shortage, but clearly more needs to be done here to deal with this at a macro level. So while we've made progress since the beginning of the pandemic, we still have a ways to go to properly protect VA employees and veterans. We're going to also examine VA's progress in implementing solutions. For example, VA has set up 8 interim warehouses to store and distribute stockpiles of masks, gloves, and other critical supplies to VA hospitals. VA originally told us that they plan to turn some of those supply warehouses into permanent readiness centers to hold 6-month stockpiles of critical items by July of 2021. Now this has been delayed until 2023. I recently introduced a bill to allow VA to participate in the Pentagon's War Stopper program, which is an additional solution for acquiring critically needed supplies. I look forward to discussing how War Stopper can improve supply chain resilience and be complementary to other efforts that are ongoing at VA. As I stressed 6 months ago, the department needs modern and effective acquisition and inventory systems to provide a permanent solution to supply chain challenges. VA has previously planned to roll out a new medical surgical prime vendor program called MSPV 2.0 in January of 2021. However, VA has since delayed this program another 9 months. This follows a long series of prior delays for modernizing VA's procurement systems going back many years. At the same time, VA is trying to accelerate its 7-year rollout of DoD's integrated supply inventory tool called DIMLS by 2 years. VA now plans to complete the transition to DIMLS by 2025, but VA has installed the system at only 1 facility and plans to add just 3 facilities in fiscal year 2021. That looks to be quite a time crunch in the coming years. So I look forward to hearing from all of our witnesses during today's proceedings and doing our part to give veterans and VA employees a medical supply chain that is reliable, effective, and efficient. I think we can all agree on that. With that, I'd like to turn things over to Ranking Member Mann for 5 minutes for any opening remarks that he may wish to make. I certainly welcome him to the subcommittee, really look forward to the work ahead, and I know we're going to be working hand in hand to make sure that our veterans get the best possible care and services that they deserve. So Ranking Member Mann, I'll turn it over to you.
Great. Thank you, Mr. Chairman. First, let me say I'm honored to serve with you on this committee and as the ranking member of the Oversight and Investigation Subcommittee. I enjoyed getting to know you better when we met at your office the other day and look forward to working with you together in this important endeavor. I spent the last 20 years as a commercial real estate broker and focused on industrial properties, which got me involved in transportation, logistics, and supply chains. I'm glad we're doing a hearing on this important topic today. Thank you for your leadership. My grandfather served in the European theater during World War II, and I'm passionate about taking care of our veterans. To that end, I appreciate the women and men working at the Department of Veterans Affairs who provide health care benefits and dignified burials to our brave veterans. Living up to the promises made to our service members is part of our constitutional obligation and our duty to care for our nation's heroes. Our responsibility here is to make sure the VA as an institution is efficient, responsive, and accountable. The programs must work. Too often, we let organizational charts and political rhetoric stop progress. This does not take care of our veterans. People do. That is why my goal will always be to foster an environment in the VA where dedicated people can succeed. I want to thank our witnesses for participating in this hearing to discuss VA's medical supply chain. I look forward to your testimony. I believe as a country, our brightest days are yet to come, and we need to begin recovering from this pandemic by opening the economy. Now is the time to begin taking stock of how VA's medical supply chain has performed and whether it has been strengthened enough for the future. A year ago, the unexpected happened and the pandemic decimated every supply chain. There was no choice but to improvise. The VA adopted a contingency posture and rationed supplies. The news reports we saw of nurses and orderlies reusing personal protective equipment day after day was distressing. VA also started several new initiatives, few of which have been completed. All we know for sure about the next challenge is that there will be one, and it will be different. I want to explore what VA has learned over the past year, specifically which innovations should be adopted permanently, and how can the new initiatives support the ongoing COVID response while also strengthening the supply chain to withstand the next challenge. Mr. Chairman, I was alarmed to learn from the hearing that you had last Congress that an end-to-end medical supply chain still does not exist in the department. As we discuss the major ongoing initiatives, I think we must emphasize unity of effort. First, there is DIMLS. VA clearly needs a more modern inventory and supply chain management IT system, and the Department of Defense is a reasonable place to look. I appreciate VA attempting to accelerate DIMLS from an 8-year implementation to 5 years, but this is still too slow. Bringing the system up to full capability at its first and only site took almost 2 years. I did not see how this program can successfully be implemented unless something fundamentally changes. I also understand there's a new version of the software called Logical set to be available in a year. This seems to put VA between a rock and a hard place. The options are to continue installing DIMLs now, only to replace it with Logical later and duplicate costs, or defer immediate improvements and wait to implement Logical. Turning to the regional readiness centers, I understand the decision to hold greater physical inventories. Tabling the fact that the centers cannot be fully operational until 2023, I'm struggling with how VA can be signing agreements for warehouses without answering some basic questions. For instance, what items will be held in these warehouses? Unless the plan is to restore massive quantities of every medical supply, how can anyone predict which items will be needed in future emergencies? And how will physical inventories be integrated with the just-in-time inventory model used by the rest of the department? VA has already committed to 2 regional readiness centers and 2 more in the process. However, before VA sinks $1 billion of taxpayer money into startup costs, not to mention ongoing operational costs, I think we need a lot more answers and to potentially explore other options. The VA does not need to start from scratch. One option is the Defense Department's War Stopper program, which you referenced earlier, which pays suppliers to hold emergency inventories on the government's behalf. Last Friday, Ranking Member Boss, you Chairman, Mr. Chairman, I introduced HR 2082, the VA Supply Chain Resiliency Act, which would require VA to partner with DoD to gain access to the War Stopper program. At the very least, War Stopper should make the regional readiness centers less risky. I believe VA sees the value in this approach, and I look forward to working together to get it done quickly. I want to thank our witnesses again for sharing their time this afternoon, and I look forward to exploring these issues in greater depth. Mr. Chairman, I yield back.
Well, thank you very much, Ranking Member Mann. We'll now hear from our witnesses. And I'd like to recognize our first group of witnesses for their opening statement. First, we have from VA, Ms. Deborah Kramer. She's the Acting Assistant Undersecretary for Health for Support, Veterans Health Administration. She's joined by Mr. Andrew Centineo, Executive Director of the Procurement and Logistics Office of VHA, and Mr. Philip Christie, Deputy Executive Director for Acquisitions, Logistics, and Construction. Ms. Kramer will provide the testimony for VA. It's really great to have you with us here today. I've appreciated our ongoing conversations, and we look forward to your testimony. I'll turn it over to you for 5 minutes.
Chairman Pappas, Ranking Member Mann, and distinguished members of the subcommittee, good afternoon, and thank you for the opportunity to discuss VA's response to the COVID-19 pandemic and our modernization efforts. Joining me this afternoon are Phil Christie and Andrew Centineo. Phil, Andrew, and I are all former Army Medical Service Corps officers and medical logisticians, and we are proud to continue to have the opportunity to serve our fellow veterans as VA employees. I would like to start by thanking you and your staffs for your continued support, including the funding in the CARES Act and the American Rescue Plan. I also want to acknowledge the support of your staff members and the GAO and OIG staffs who engage with us on a regular basis to review our performance and actions and provide objective evaluation of our plans. Our plans are better prepared for their efforts. Dr. Stone's guiding directive to VHA was to save every life you can. And I want to thank our VA healthcare staff who continue to show up to fight the COVID battle every day, and who continue to keep our nation's veterans and their communities safer. For over a year, VHA staff at every level of the organization have worked around the clock, 7 days a week. Media has provided all of us with a view into the commitment, sacrifices, and achievements of our frontline clinical staff, and deservedly so. Today, I'd like to augment the written statement we submitted with 3 stories to describe the contributions of the behind-the-scenes staff who are equally critical to VA's medical response efforts. In March of last year, VA was acquiring tents to increase the number of beds for COVID-19 patients. The contract required the vendors to set up the tents. However, vendors were unable to deploy personnel due to COVID travel restrictions. Our Vision 22 contracting branch chief, a retired Army medical and biomedical engineer, leapt into action and mobilized volunteers from the contracting, logistics, engineering, and safety offices, and they installed the mini hospitals next to our VA medical centers. When I visited the VA Medical Center in Baltimore, Maryland, Because of the ingenuity of the engineering and facility staff in expanding negative pressure space, the first thing I thought of was Apollo 13. The Apollo 13 NASA ground team had to design an adapter to allow a rectangular command module CO2 canister to fit onto the round CO2 canister housings in the lunar module, using plastic bags and duct tape. The Baltimore team had to expand negative pressure space to doorless dental clinic treatment rooms. They did so with a combination of construction zipper doors, portable construction, negative air machines, new ceiling air duct pipes, and duct tape. And they did this in just days. Finally, I want to recognize the efforts of the VHA Procurement and Logistics Office, or PLNO. Before COVID, PLNO provided policy, oversight, and contracting. When the personal protective equipment global supply chain faltered, PLNO took on an operational mission to build resiliency into VHA's internal supply chain by establishing and operating regional readiness centers to act as a central source for management and resupply of PPE. PLNO's efforts ensured VHA was able to sustain VHA healthcare operations, and their efforts continue today. These employees were driven by their belief in VA's mission and their commitment to our frontline healthcare staff and to veterans. When time allows, there are countless other stories I would like to share with you about their dedication and tenacity of all of the behind-the-scenes employees. With respect to VA modernization and performance management, in FY20, VA obligated $26.7 billion using disciplined category management principles and achieved 126.9% of the OMB spend under management goal. This represents the highest spend under management of any civilian agency. For medical, we achieved over 82% of the $19.7 billion in spend under management. VA remains committed to our small business partners. In FY20, VA obligated approximately $7.4 billion in contracts with service-disabled veteran-owned small businesses, which exceeded our goal by about 5%. For our COVID response, VA spent $1.8 billion in contracts to small business, with 82% going to veteran-owned companies. Your support remains essential to our continuing efforts to provide excellent care for veterans and their families, and I'm grateful to the committee for your partnership. My colleagues and I look forward to answering your questions.
Well, thank you very much, Ms. Kramer. Our next witness is Mr. Michael Missel, the Inspector General for the Department of Veterans Affairs. I'll turn it over to you for 5 minutes.
Thank you, Mr. Chairman. Chairman Pappas, Ranking Member Mann, and members of the subcommittee. I appreciate the opportunity to discuss the Office of Inspector General's oversight of the Department of Veterans Affairs Supply Chain and Logistics Program. VA employees working in its medical facilities have reported to the OIG time and again that core systems like procurement, inventory management, and logistics affect their ability to provide veterans with timely and quality health care. VA has further faced numerous challenges with their information technology systems and other structures that support these critical functions. The pandemic has stressed these foundations in ways one could not have anticipated even a year ago. Before I discuss the issues before us today, on behalf of all OIG staff, I want to express our deep gratitude to the many VA employees who have worked tirelessly during the COVID-19 pandemic to serve veterans, their families and caregivers, and in many cases, members of their local communities, often at significant risk and great personal sacrifice. We also appreciate the COVID-19 related funding from Congress supporting our efforts to conduct associated oversight work. This will enhance what we do to provide VA with recommendations and information its leaders need for continuous improvement. The OIG's mission is to conduct effective oversight of VA's programs and operations, as well as ensure VA funds are appropriately spent. The OIG has frequently examined VA's supply chain because of its tremendous costs, scale, and effect on patient care and employee safety. Prior to the pandemic, OIG reports identified IT, contracting, and staffing problems that have contributed to some VA medical centers not consistently having supplies when and where they needed them for patient care. My written statement includes details of some of our more recent reports on this topic. In sum, facilities have long experienced barriers to real-time tracking of inventory, purchasing, distribution, storage, and other supply management functions. This has led to breakdowns and the need for workarounds that sometimes lack compliance with VA policies and procedures. The COVID-19 pandemic has intensified these problems with disruptions to supply chains and unprecedented demands on healthcare delivery worldwide. Limited supplies affect not only patient care, but the protection of VA personnel working on the front lines. In efforts to report as timely as possible, the OIG has proactively conducted oversight work of VA actions during the pandemic that demonstrate VA's need to quickly layer tracking dashboards and processes on top of its flawed supply chain foundations. Although VA has significant experience and success in handling regional disasters, the global pandemic has changed how VA is needed to compete with all public and private healthcare systems for scarce but critical supplies. VA staff have needed to develop creative strategies, structures, and workarounds to mitigate the effects of supply shortages. In addition to our audits and inspections, we have also worked with VA, manufacturers, and our law enforcement partners to identify and prevent crimes that divert critical healthcare supplies from VA, siphon its funds for counterfeit goods and price gouging, and other criminal activity. We appreciate the VA staff who have brought significant tips to our attention. We have already obtained a number of convictions and have many criminal cases ongoing. The OIG applauds the work of the subcommittee and VA in continuing to raise as a priority the need to improve VA supply and logistics systems. The oversight work detailed in the statement reveals there are still considerable challenges related to VA's administration and oversight, even without the strains the pandemic has placed on medical and surgical supply chains. The OIG is committed to providing practical recommendations that flow from its inspections, audits, reviews, and investigations to help VA deliver quality healthcare to veterans and safe working conditions for all VA personnel. Chairman Pappas, this concludes my statement. I would be happy to answer any questions you or other members of the subcommittee may have.
Thank you very much, Mr. Missel, for your testimony. And we have one final witness with us here today. It's Ms. Shelby Oakley, a Director of Contracting and National Security Acquisitions for the Government Accountability Office. You have 5 minutes.
Chairman Pappas, Ranking Member Mann, and members of the subcommittee. I appreciate you having me here today to discuss our ongoing work on VA's COVID-19 procurement response and other recent work focused on VA, including our 2021 high-risk list update on VA acquisition management. As you are aware, at the committee's request, we have been monitoring VA's COVID procurement response from early on in the pandemic. I have testified previously that COVID-19 presented VA with unprecedented medical supply chain challenges. While these challenges were met head-on by VA staff, as Ms. Kramer described, they also illuminated long-standing weaknesses in VA's supply chain. These weaknesses persist due to VA's fragmented and siloed approach to its ongoing initiatives, which has resulted in many unanswered questions. For example, we have been examining one of these initiatives, VA's Medical Surgical Prime Vendor Program, for many years. During this time, there have been continual problems and constant changes in VA's approach to this program. VA's decision to wholly move to DLA's Medical Surgical Prime Vendor Program in lieu of its own program is the most recent example of such change. While it could ultimately make sense for VA, making the decision to move ahead before assessing the outcomes of its pilot, as we recommended, comes with risk. Furthermore, VA and DLA serve different customers, and VA has specific legislative requirements, such as Veterans First, that need to be met when contracting. It remains unclear how these agencies will work together to ensure that VA's needs are met. VA has also begun 2 initiatives in response to the pandemic. For example, VA is taking steps to try and better respond to future health emergencies through standing up regional readiness centers and seeking to participate in DLA's War Stopper program. However, VA has yet to address key questions about these new supply chain initiatives, such as how much funding will be needed upfront and on an ongoing basis to support these concepts. Additionally, while these initiatives seem to make sense in the context of responding to an emergency, questions also remain about how or if they complement or duplicate one another. In other words, if VA plans to move forward with what seems to be a belt and suspenders type approach, it needs to clearly articulate how doing so supports its emergency response goals without introducing unnecessary duplication over the long term. VA has developed plans of varying maturity and completeness for its individual supply chain initiatives. However, these initiatives do not exist in isolation, are highly interrelated, and their success requires fundamental change across the entire agency. The VHA Modernization Campaign outlined a number of in-progress initiatives across the full scope of its operations, including several related to supply chain. While VA updated the modernization plan in October 2020, it still does not provide a comprehensive strategy that communicates how each of its various supply chain related initiatives move it forward toward a more modern supply chain. Importantly, it lacks an implementation plan with key milestones and deliverables to track progress and support and informed decision-making at an enterprise level. A comprehensive strategy would help VA balance different objectives and identify steps needed to create long-term gains, not just short-term advantages. Without one, VA risks missing opportunities and wasting resources. As a result, today we are recommending VA develop a comprehensive supply chain management strategy. We are not out of the woods yet with this pandemic, but focusing on the future is important because the hard work is not over. Addressing the issues I discussed today, and as outlined in my written statement, will not be easy. It requires leadership commitment that is strategic and sustained over many years. Until it develops a comprehensive strategy, VA will not be able to put in place an effective medical supply chain that delivers the right item at the right time to the right place and at the right cost, or make significant progress to address its high-risk acquisition management and ultimately better meet veterans' needs. Mr. Chairman, Ranking Member Mann, and members of the subcommittee, this concludes my oral statement. I'll be happy to answer any questions you have at this time.
Well, thank you very much for your comments. I know we'll be interested in exploring some of those topics in the question portion. We will now turn to that portion of the hearing, and I'll start by recognizing myself for 5 minutes of questions. And I want to begin on the issue of the War Stopper program. We know, like other medical systems, VA hospitals across the country have worked really hard to procure the supplies and materials that they need to meet the ongoing health crisis, keep their patients and staff safe. There have been really heroic methods that have been undertaken to avoid major shortages. Rationing and shortfalls did occur at specific locations. The Pentagon's War Stopper program did provide some hard-to-find items, including over 1 million N95 masks, 1 million exam gloves, and 90,000 isolation gowns to support the nation's pandemic response. Unfortunately, VA is still not an equal participant in that program. Ms. Kramer, I'm wondering if I could start with you. I want to explore a little bit the situation with War Stopper. I'm wondering if you could comment on why VA wasn't a full participant in the program before the pandemic began, and efforts that VA is undertaking to seek full participation at this time.
Sir, thank you. I cannot speak to why we weren't in it before. I've only been in this role for a year now, but I can tell you that we are looking for participation in that. We see no impediments to our being able to use it, and it actually is complementary to what we want to do in the regional readiness centers. We don't want the regional readiness centers to become places with large amounts of material. Most of the stuff is going to have an expiration date with it. And so being able to partner with DLA inside War Stopper would allow us to do things like vendor managed inventory, where that material, we pay the manufacturer to hold a certain amount of material, tell them that they have to be able to deliver a certain amount within a certain amount of time with a certain amount of remaining shelf life. And that keeps the costs lower. We still have the ability to surge when we need to. We're still going to be relying on our Med-Surg Prime vendors. But there's no reason to pile up large amounts of material in a warehouse if we have a program like the War Stopper to support us.
Well, I appreciate those comments, and I think you're aware that a few days ago, both ranking members Bost and Mann, as well as myself, introduced the VA Supply Chain Resilience Act to require DoD to allow VA to participate in War Stopper. It's a bipartisan bill written as a result of conversations that we've had with VA, including some of the witnesses who are here today following the September 2020 hearing that we held. I'm wondering if you had any comment, Ms. Kramer, on that legislation, if you would be able to take some time to review it and give us additional feedback. And if you do have some understanding of it, if it became law, what that would do to VA's access to medical supplies in a future crisis like this.
Well, sir, I've read the bill. It looks like it would be very helpful to us, but DLA is already saying that they're willing to cooperate with us on this. The plan could take a little more than 6 months just because as a part of this, DLA has a very structured process for how they evaluate the capability of the industrial base. That's how they decide whether they're going to buy raw materials or piece parts that go into something or rely on something like vendor managed inventory. We would like to use the process that DLA has developed to do that. It is a proven process. We don't need to invent a duplicate one here. We have to make sure we understand how long that is. We can find that out from DLA and get back to you so that that could be included, a realistic time frame included within your bill.
Okay. Well, I look forward to those conversations. I'm wondering if I can move to Ms. Oakley and talk a little bit about the high risk list. I appreciate your comments on that and your testimony. VA has shown some progress in addressing the acquisition management deficiencies over the last couple years. I'm wondering if you could talk a little bit about that progress and what we should be looking for in the next 2 years so that we're identifying the kind of progress that's going to allow them to fix these major problems.
Absolutely. I'll be quick here. VA has made some progress since our last assessment. We have given them some credit for leadership commitment to addressing the high risk issues and capacity. But the biggest thing that VA has yet to do that's going to drive a lot of the rest of the improvement in the high risk area is the development of a high risk action plan. This action plan should really include a number of discussions of root causes of what some of the biggest acquisition management challenges are. And I think it's clear from the pandemic that VA supply chain management challenges are one of those root causes of some of its overall acquisition management challenges, and development of that comprehensive supply chain plan would feed right into that root cause analysis and the high risk action plan.
Well, thanks. I'm out of time. I hope we can pick that up in a second round. But for now, I'll turn it over to Ranking Member Mann for 5 minutes.
Thank you, Mr. Chairman. I have some questions for Ms. Kramer first, and I share, Mr. Chairman, your priority in getting the War Stopper program up and running. Some of the questions you had were actually some of the same questions that I had, so I was going to start there. My question, I guess, as we continue to get into this with Ms. Kramer, I know you interact with the DLA often. After all, they're providing the warehouses for the regional readiness centers. What exactly do you think needs to happen with DLA to get the VA into the War Stopper program?
I think, sir, that we have to identify specifically what we want to use that War Stopper for. See if there's some commonality with what DoD wants to do. There's also an interagency group working under a recent executive order, just looking at PPE in general in the United States and pandemic readiness. So there may be opportunity to make it larger than just DLA and VA. We need to give that process time to work its way through. I think that's going to allow us, then we just have to decide on it and set up the interagency agreement that will allow us to proceed.
And how long do you think potentially that could, if we got focused on it and worked to expedite, any sense on how long all that could take?
I think it could be done in less than a year. Again, it's the industrial base aspect and evaluating what the industrial base can do. That's the part that takes some time. It's that upfront work that then helps you actually identify how you're going to negotiate what you want to do with industry to begin with. We've got to give that process sufficient time. That is DLA's area of expertise, and I can't speak to the amount of time that requires.
Yeah, okay. Mr. Kramer, so shifting gears a little bit to demos, rolling out a new enterprise software package, involves a lot of technical prep work, process design, training. How far along are each of those efforts, and how close are you to getting demos up and running at a new site?
Right. Well, this is the first year that the DIMLS program as an enterprise program has actually been in our budget. Everything done with DIMLS prior to this was done as part of a VA-DoD joint initiative. And so that was just a test to see if at the James A. Lovell Federal Healthcare Center, we could establish a common system. That hospital is run by both Navy and VA, both using before this a separate supply chain management system. So this was the test there. So this is the first year that we have had the program. And if COVID had not occurred, we would have moved out much faster than we have. COVID has impacted our ability to be able to, for instance, deploy personnel to conduct training at a hospital site. The good news is we're bringing on a new executive director for the VA Logistics Redesign Program, or VALOR. He onboards next week. He is a retired Army Medical Service Corps officer with a strong background in IT, in medical logistics. He's been a hospital director, so he's going to understand our customers' perspective. And we should be able, barring further slowdowns based on COVID disease rates, be able to begin deploying additional sites this year.
Okay, so as early as later this year. And then
Yes.
how does it make sense to install DIMLS anywhere else if we're going to replace it with Logical in a year or so? We're kind of at this odd spot in the timing of those. We're going to be spending time and resources installing what then pretty quickly is going to be an outdated way of doing things. Any thoughts on that?
Yes, sir. The big thing that changes between DIMLS and Logical is that the supply chain management system moves into the cloud. And for the user, much of it is going to be seamless. They'll still click an icon on their desktop, but it's going to take them to a cloud version as opposed to a server-based version. And a lot of what it is you'd actually have to open up the hood and look inside the engine to see what's going on. It's the way the system itself is put together. It really does make sense. We frankly, sir, can't delay. We need DIMLS because we don't have a supply chain management system in VA. We have an inventory management system that can't even take an expiration date. There's no field for expiration date in that system. The longer we delay, the longer it'll take. So we need to begin rolling out now.
Okay, and knowing that is going to then be replaced mostly by Logical. Am I thinking about that correctly?
That's correct, sir. DIMLS will be replaced by Logical. Basically, it's DIMLS moving to the cloud with a new name and a lot of different things inside the engine.
Okay. That's all I have for now. I'll yield back, Mr. Chairman.
Thank you. Next up, I'll turn it over to Representative Lamb for 5 minutes.
Thank you, Mr. Chairman. Ms. Oakley, I saw in your testimony a comment that the VA will have to evaluate the way it complies with its obligations toward veteran-owned small businesses going forward in light of the need to modernize this supply chain. And I was just wondering if you could say a little bit more about that. Do you have some concern that they sort of cannot serve both masters, or what was behind that comment?
Absolutely. Thank you for that question. Yeah, we do have some concerns, and I think it's based upon past experience, but also what we're seeing in the plans and discussions going forward. And so VA's imperative to contract with small businesses isn't going anywhere. It's something that VA is going to have to contend with as it makes any of these decisions. The agencies that it's looking to partner with, like DLA, don't have the same requirements. Okay, so when you're talking about making decisions and partnerships that require another agency to contract on your behalf and not account for those specific requirements, it raises a lot of concerns. We've seen in the past on programs like the Medical Surgical Prime Vendor Program where these considerations weren't fully considered as VA made some different changes, and it led to many protest decisions and many delays in those programs. And so that's what we want to avoid. And with this partnership with DLA on its MSPV program, we're not seeing great consideration to what those concerns are. And in fact, some of the rhetoric and documentation I'm seeing is basically just relying on getting relief from those requirements. And I don't think that's a realistic consideration at this point. And so any effort that VA puts into place where it's partnering with another organization is going to have to consider how it will comply, not just with the spirit, but with that law.
Well, I really appreciate you putting that emphasis on it. And I would, just add to that for our VA witnesses that we're coming out of a pandemic that has just crushed small businesses all over this country. Huge rate of closures and shutdowns and all the rest of it. There would never be a worse time to fail in our obligations toward veterans-owned small businesses than now. And so I have 2.5 minutes remaining. I don't know if our VA witnesses have an answer on this topic yet, but I'd appreciate it if you could address some of the concerns Ms. Oakley raised and any plans you have going forward to make sure that we do fulfill our obligations, not only under the law, but the moral obligation that we have to help veterans who have taken the step of starting their own small business.
Yes. Phil, do you want to take that?
Yeah. Hey, good afternoon, everyone. I just want to add some clarity to some of the testimony just given there. The VA and the DLA are working very closely on this concept of VA moving to DLA MSPV program, both at the commanding general level in Philadelphia and the senior levels within the VA are absolutely committed to make sure that the veteran-owned business community is at the table, is participative in the concepts, and has opportunity to gain contracts. We will be, if you will, taking the complete list of veteran-owned companies at the VA, sharing that with the DLA team, creating matchmaking sessions. We've had a few of those already. We're actively engaged with multiple professional organizations, sharing these concepts, talking about how do you get that business. And I'll share with you, right, if a veteran-owned company does go through those procedures, now are they not only having business at the VA, but now they have another opportunity with the larger DoD, and that's the Army, Navy, Air Force, and Coast Guard, and others that are using the DLA program. Absolutely committed to making sure the veteran-owned community is there, and DLA's leadership has been, without a doubt, committed to that outreach program and to ensure they have opportunity.
Great. Well, I appreciate you weighing in on that. I'm about out of time, but I would just say, please let us know if that changes with DLA or there are resources or ways that we can help, because I think I can speak for virtually everyone in the committee to say it's very important to us that we make sure we fulfill our obligations there. And Mr. Chairman, I yield back.
Thank you. I now recognize Ms. Radewagen for 5 minutes.
Thank you, Chairman Pappas and Ranking Member Mann, for holding this hearing, and thank you to the panel for your appearance today. Ms. Kramer, how are you going to set up the regional readiness centers to prepare for an unknown future pandemic and at the same time strengthen the supply chain in normal conditions?
Yes, it's related. As we heard from Ms. Oakley, this has to be an integrated strategy, using all of the capacity that we have today with our prime vendor programs, with our national contracts, and then what we do is we layer on the regional readiness centers. I think what Andrew and Phil and I bring to this is, having been Army medical logisticians, we understand how DoD has done that to be able to support deploying forces and surge requirements. And that means modeling the need. And our regional readiness centers are actually there to do more than just pandemic response. As we get past COVID-19, we're looking at all hazards readiness. So they're able to support earthquakes, hurricanes, and those kind of things that also create great disruption in the country.
So, Ms. Kramer, please walk me through how you're locating the regional readiness centers. So far, they're all going into existing DLA, as was mentioned earlier, the distribution centers. Those are certainly strategically located for military installations, but are they optimal locations based on where the VA medical centers are?
Let me direct that question to Mr. Centennial.
Sure, thank you. Yes, ma'am. Great question. So the VA or VHA is broken up into 4 geographic regions: the VA Northeast, the Southeast, the Midwest, and the West. And as was mentioned earlier, we are looking to make these geographically dispersed and geographically co-located with our VISNs, the Veteran Integrated Service Networks. And today we have 2 permanent locations, as was mentioned, DLA warehouses and DLA complexes. One is in Defense Distribution San Joaquin Valley in California. The other one is the Defense Distribution Susquehanna, Pennsylvania. So those are geographically co-located with the Northeast and the West regions. We are still working towards our Southeast and our Midwest locations. The first 2 mentioned are DA owned and DLA operated. The other 2 will likely be contractor owned and contractor operated, because we want to be able to get access to facilities that are optimal for the locations and the support needed. And those 2 are still being worked. And that's why you've heard we actually have 9 current warehouses in 8 locations, as the others that are not the 2 are interims. We will migrate out of those, and we're only going to lose about 102,000 square feet as we close the others down. And then we will stand up the other ones in the Midwest and the Southeast as we mature those. Again, the current requirement is PPE. They will evolve into geographically aligned requirements as well. For instance, the Gulf Coast in the Southeast may have something that's tied more towards hurricanes. Out west in the California area, we may actually have things like forest fires. There are going to be certain things that will be a little bit different in each of those, but they will build in capability for backstops. So if there's a storm in the Northeast and the one in Pennsylvania has an impact, we could turn to the others to also be able to have reinforcing support. So at no time will the VHA ever go without support. And as required, and if needed, we could expand that to have reinforcing support if called upon for a 4th mission.
So how are you going to make the centralized inventory model of the regional readiness centers align with the just-in-time inventory model in the rest of VA? Ms. Kramer or sir?
Great question. So the RRCs and War Stopper will be complementary, as was mentioned earlier. Our primary opportunity, or our primary means of getting our supplies, is through our MedSurg Prime vendor. Those that are War Stopper will be vendor managed inventory. That will be managed out to the commercial space. Our RRCs will be managed to rotate our materials into our active inventory, so we mitigate risk and we rotate those things that are expiring. It will be done in a complementary way, not in silos or in isolation.
Thank you, Mr. Chairman. Yield back.
Thank you, Ms. Radowagen. I'll now turn it over to Representative Luria for 5 minutes.
Well, thank you. I want to say thank you to our witnesses and to Chairman Pappas and Ranking Member Mann for holding this important hearing. I wanted to focus on an issue that I learned about at our local VA and was also mentioned in a September 26, 2019 VA Office Inspector General report about the mismanagement of equipment and supplies at the Hampton VA Medical Center. The report stated that the medical center did not use available inventory systems to track supplies, supply orders, storage, and as a result, the IG reported that about $1.8 million of unused equipment was, which was unaccounted for, was discovered in an unmarked room. And moving forward, the facility director designated someone to manage this inventory and develop a process to make sure that logistics service staff followed protocol and managed this equipment. And the Hampton VA Medical Center notified my office that they followed all recommendations following this incident. But Inspector General Missel, we've talked here about how the VA is going to adopt the DEMLS system to have better accountability, but there's quite a long time frame. If I understand, like 5 to 7 years for this to be implemented. Are there any best practices or anything that the VA medical centers can use to manage inventory control in the interim?
Yes, absolutely. And this report, I think, is significant in a number of ways. First of all, we learned of the issues in Hampton through a confidential informant. We rely heavily on people providing us information, and we treat their request for confidentiality very strictly. So it was great for us to get this information. You identified the major issues, that they had equipment in rooms where nobody knew it was there. It was about $2 million worth of equipment. But where I think it was particularly disappointing to me was we got the information on Hampton in August of 2018. the year before, in April of 2017, we put out a report on the DC medical facility, which identified almost similar issues to what we later found in Hampton. And that DC report got a lot of attention, as it should have, because you had a large medical center with many controls that were failed. And our expectation would be when we put out a report like that, because Hampton was using the same inventory system as DC was, that it's not only just for the DC Medical Center, obviously we had recommendations there, but other medical center directors, other VISN directors should look at these reports and say, do I have the same issue? Had they done that at Hampton, they could have identified it sooner. So they, as you point out, they have closed out the recommendations. We do make recommendations that are thorough, that address the issue. We have not heard of any issues currently, but we do go and inspect facilities on a regular basis, and we'll be back down to Hampton in the near term.
Well, thank you, and thank you for your insights into that. Another thing that I've learned of from employees at our local VA, the Hampton VA, specifically some who are part of the American Federation of Government Employees, AFG, very concerned about the quality of their PPE that they're being provided. At one point, there was an extreme shortage of PPE. There continues to be ongoing quality issues. I've been told that employees are being given non-surgical face masks and that they're poorly made. And according to the VHA Procurement and Logistics Office, the data that we were given is that Hampton has over 212,000 surgical masks on hand, and they use about an average of 1,000 per day. I'm not sure the person to address this, but is there a reason that the employees cannot be given access to over 200,000 masks that are available at the facility?
I'm not aware of that. I know that we've looked at that across a number of the medical centers in terms of the quality. We have had a number of instances where we've identified counterfeit PPE that's been sold to VA, and we've been aggressive on that and bring people to justice who do that. But it would be up to each individual facility to ensure that the PPE they're using is of the appropriate quality.
Okay, and is there something that if the employees are still receiving PPE that's they feel is not of sufficient quality, is there a process for those employees to report that in their chain of command at the medical center or otherwise?
I'm not aware of that, and we would certainly get complaints that come in. We review all the complaints on a real-time basis that we get. We share them with VA as well. So if we had a complaint like that, we would work through it with the facility to ensure that the staff are getting the appropriate PPE.
Okay, well, thank you again for your insight, and I apologize to Chairman Pappas for running over my time, but thank you again.
Not a problem. Thank you very much. We can go into a second round now. I know I have a few more. I'm sure Ranking Member Mann does as well. Ms. Kramer, I just want to pick up where I left off with Ms. Oakley talking about the high-risk list. Recently, I noticed that VA had yet to finalize its action plan, and I indicated that in a letter I sent to Secretary McDonough on March 2nd, requesting this action plan, specifically to lay out how the department would get off the high-risk list and improve VA acquisitions. I'm just wondering if you can shed any light on when VA is going to finalize this plan.
Sir, the plan is to be delivered to GAO by the 31st of this month.
Terrific. Well, we really look forward to seeing that as well, and appreciate those comments. I do have some additional questions, and maybe Ms. Oakley could pick up on a comment that you made about the need for a comprehensive supply chain management strategy. I think those were your words in your testimony for VA. Could you talk a little bit about that recommendation, what VA is lacking in its current plans, and how that would all be tied together with the strategy that you envision?
Absolutely. Thanks for that question. Yeah, what we see right now is kind of twofold within VA. At one level, the plans aren't detailed enough, and at another level, at the more granular level, they're kind of at varying stages of maturity. So let me start with a not detailed enough comment. So VHA does have this campaign modernization plan that has supply chain as a part of that effort. And so it kind of goes through and outlines each of the supply chain initiatives that are a part of VA's modernization efforts. And then it lists goals for how we measure success. And one of those goals, for example, is SDVOSB use. But nowhere in the plan does it define what SDVOSB use means, or does it mention anywhere else in the plan how those initiatives are going to help you get to that goal of SDVOSB use. So what we'd like to see in a comprehensive supply chain strategy is more details and more integration of those supply chain initiatives that would allow VA to demonstrate how it's going to achieve its overarching goals toward attaining a more comprehensive and modern supply chain. So that's one part. The other part is at a more granular level, some of these initiatives are just underway and have very immature planning surrounding them. And so we'd like to see a little bit more detail in those plans to be able to have a basis for understanding with confidence how these plans are going to contribute to VA's overarching goals. So these would be things like providing schedule baselines and cost estimates that have, a certain amount of fidelity associated with them. The important point of this type of plan is that while it would be a living document and would continue to grow as VA learned and continue to progress in its efforts, the baseline would be set, and it would allow Congress and GAO and the Inspector General to hold VA accountable for doing what it says it's going to be doing to meet these lofty goals.
Well, I appreciate that. And I'm wondering if I could get VA's reaction to that recommendation. Obviously, you've presented, various crucial pieces of this puzzle. And I'm just wondering about the development of some of the finer points that Ms. Oakley referenced of a comprehensive strategy that we can use to hold you accountable and to see the full roadmap of where we need to go as we move forward.
Ms. Oakley, spot on. That's exactly what we need and what we are committed to providing. To get to that level of detail and pull all these efforts together is going to take some time. So in the acquisition management high risk list plan that VA is going to be providing, it'll still be at a high level. But as we move through a few more months into this year, hoping that COVID stays at bay, we'll be able to start to put those things together. But that recommendation is exactly what we need to be doing so that you understand what we're doing, so you can assess the reliability of our plans, and you can hold us accountable for what we say we're going to do.
I guess, is that something that was already in progress at VA? Or I guess what sort of obstacles stand in the way for that kind of a plan to come together?
I think the only obstacles that stand in the way are we are limited to 24-hour hours in a day and 7 days in a week. That is the only thing holding us back.
Well, terrific. Well, hopefully we can continue to connect about that. I think that recommendation gets at the heart of the purpose of this hearing and what we hope to flesh out as we move forward. And so, seeing that my time's expired, I will turn things over to Ranking Member Mann for 5 minutes for additional questions.
Thank you, Mr. Chairman. I kind of have two sets of questions, if you will. The first one would be for Ms. Kramer. The VA submitted inventory data for personal protective equipment at selected medical centers. One of them is in Wichita, my home state. It says that almost 37,000 N95 masks are on hand and only 13 are used over a 3-day period. That works out to an almost 8-year supply at our current usage levels. I guess I have two questions. First, why is our usage so low?
Well, the usage is based on what you're seeing in terms of a day and supply on hand is based on what's going on at that facility at that very moment. So it very much relates to the number of patients in an ICU bed or in the emergency coming through the emergency room. We've got a plan for surges, and so while it looks like eight years today, given what the current patient levels are, You're seeing the same news I am in terms of rates going up, which means the days of supply on hand goes down as the need for more of those N95s come up. I wish we had a better metric than days of supply on hand. It's an imperfect one, and I'd welcome anyone who's listening to this, if they've got a better one, to let us know about it. But that is why. We've got a plan for worst case.
Okay. And then secondly, do we still have any restrictions on using N95s to conserve supply? And if we do, why is that?
Sir, nationally, there are still shortages of N95. In fact, the FDA has it's the FDA has a COVID device shortage list. It lists both medical grade gloves and N95s and surgical gowns and isolation gowns as being something expected to be in short supply to the end of the pandemic. And when we say the end of the pandemic, that means after everyone in the world is immunized, because it is a global supply chain, it is global demand, and we compete with everyone else. We really don't feel that we can go back to conventional use of PPE in VA if there are other hospitals around the United States and healthcare givers that can't get enough PPE to get out of the crisis level. We need to move forward together as a nation.
Okay. Thank you. And my second set of questions is really kind of the similar vein as Chairman Pappas, do you think? So it really sort of gets to the heart of I think, where we're heading or what we need to be addressing. And I don't want to be duplicative at all. But Mrs. Oakley, so understand you're recommending that the VA develop a comprehensive strategy to manage the various initiatives to modernize our supply chain. That makes sense to me. Does a VA do we truly have a medical supply chain, meaning visibility of the items that are requested, purchased, delivered, paid for, inventory? Like, is that in place to then modernize, or where does that really stand in your mind?
The short answer is no, and I think the pandemic illuminated for all of us that VA doesn't have a supply chain that supports that kind of visibility that's necessary for an end-to-end look at what's going on. And just to, I appreciate Ms. Kramer's confidence about obstacles in the way of putting in place a comprehensive supply chain strategy, but it's going to be a complex effort because these challenges that VA faces with regard to its supply chain span all of VA, right? Many different stakeholders, many different equities, speaking different kinds of languages, right? You have people that work on systems type things, logisticians, you have medical professionals. And so being able to get all those stakeholders together to develop a strategy and to buy into a strategy to move that supply chain management system forward is going to be a monumental task. And I'm sure Ms. Kramer is up to it and her folks, and I appreciate the confidence, and I look forward to seeing, you know, what they do in that regard.
I agree with you. It's a monumental task. Before politics, I did industrial real estate, doing supply chain consulting, and you know, the private sector, everyone deals with the same thing. You have these silos of different bits of data to varying degrees of accurate, and then they've got to talk to each other, and you've got to kind of see the front to back. I guess a question for the Inspector General: anything to add to the conversation about the need for to modernize and to have a more complete supply chain that has more visibility and make sure that veterans are getting the products that they need?
Yeah, I've got a number of things to add to that. I mean, one of the things that I think we should focus on is the continuity here. You know, on the supply chain, you know, you had Catamaran before you had the generic inventory package. Now you've got DIMLs. And so you have different systems being put in place. And it all comes down to a number of things. One is a governance structure. And certainly with the DIMLs, it's great to hear we have new leadership coming on board. But I think they've had 5 leaders in the past 3 years of the program that oversees that. As Ms. Oakley mentioned, planning is just so critically important. And what we found in many of our reports is that they just don't plan as if they should. And then they need to use IT in a more effective way. IT should be the assistance here, but unfortunately, we've seen where IT just hasn't worked, and to make sure they have staffing, training, and controls in place. So there's a number of things that really need to be done correctly for these systems to work.
Oh, I realize I'm over time. Can I ask one more quick question, Mr. Chairman? I realize I'm over my time.
Well, we can go for another round if you have some additional questions. I know I've got a few.
Oh, okay. Yeah, go ahead then.
Okay. Well, I think I'll pick up with Mr. Missel as well. I appreciate those comments. And I know that in the last session, our subcommittee worked on legislation to grant your office subpoena authority. The bill was by Congresswoman Rice. It was approved by the committee with bipartisan support, but the schedule didn't allow it to become law. I'm wondering if you could comment on this particular piece of legislation, if you still think that's important.
Sure. Well, we greatly appreciate the effort last session. We think it's critically important to our work. Our goal in our work is to make sure that we're accurate and fair in all of our work. So for us to do that, we really need to be able to get as much information as is out there. And we have lots of powers to get information. VA staff are required to provide us information promptly. That would be documents, that would be testimony or interviews if we need it. But we cannot right now compel people outside of VA to testify. And so much of our work is based on interviewing people so we can understand what best happens. And so that's a gap in our information that we can get for our work. Let me give you a recent example that I think really underscores the importance of this. The Toma, Wisconsin facility has a dental clinic. And we received reports that a dentist was not using sterilized instruments in serving veterans. So we went to speak to this dentist, and he immediately resigned from VA. We thought, okay, well, let's speak to his supervisor. Maybe the supervisor would know, is this true? How long has it been going on, et cetera. The supervisor also retired. We obviously asked both of them if they would talk to us voluntarily. Neither one did. So we were able to still gather enough information to reach our findings, but our work definitely would have been benefited from that. And there are many other examples like that. And that's why testimonial subpoena authority is really critical for our work.
Well, that's great. I know we're going to be working on legislation moving forward, and we hope to stay in touch with you about that.
Great, thank you.
Beyond that, just getting back to the supply levels and your take on kind of the visibility into supplies. I know that we received some up-to-date data from VA that doesn't really get down to the individual facility level. I know things have been sort of uneven across the country in terms of the experience of a local clinic or a medical center in terms of what they're seeing on the ground. I'm wondering if you feel like we have an adequate grip on where all of these individual facilities stand with their supply needs and inventories, knowing that sometimes facilities are so far from a medical center, to get the backup that they might need.
Right. I believe it's improved over time. VA first put out guidance in February of 2020, and we went on site in March 2020, again, ensuring that we followed all appropriate protocols for safety. And what we heard from medical center directors and other leaders of facilities was that they were concerned about supplies, including PPE at that time. We went back out several months later, we did this virtually this time, and the results were much better. The concern we have is that much of this is self-reporting, and while VA has really done a yeoman's work to create tools and dashboards to look at it, it still relies pretty heavily on manual entries, which is subject to potential mistakes and doesn't have the controls as well. In our recent CHIPS, where the CHIPS are our inspection program, the comprehensive inspection program, where we are virtually inspecting facilities. Again, anecdotally, we're hearing better reports about the supplies that they have on site. So I think I would say it certainly has gotten better. VA's worked very hard on this. I think it showed, when they have an objective, they can certainly achieve it. But I think there still is more to be done, and our oversight work is continuing.
Well, thank you for those comments. Ranking Member Mann, any additional questions?
Yeah, just following up previously, I guess to close the loop on the modernization of the supply chain, a question for Ms. Kramer. I just want to make sure I understand. Is an end-to-end medical supply chain on the horizon, or where do we actually stand?
Well, DIMLS will give us the capability to do end-to-end supply chain management, along with EHRM. One of the reasons that VA wanted to go with the DIMLS solution is that DoD has already integrated EHRM and DIMLS. So what we really don't want is a nurse having to order through DIMLS and then go back to take care of patients in EHRM. They're going to have a level of supplies at a clinic or in a CBOC in EHRM. It will be able to place orders to DIMLS once that's fully out there. So we will have end-to-end management. But DIMLS is more than just supplies, right? DIMLS does biomedical maintenance. It does facilities. It does all the things you need to run a facility out there. And right now, those are in separate systems. For example, we heard about equipment issues and not knowing what equipment is there. VA has 3 separate equipment accountability systems that are used, all stovepipe. None of them talk together. The data length and the fields are all different between them. We need one system. There should be one central source of truth for all of this data. And that is another thing that DIMLS will do for us.
Okay. And then a little bit unrelated, but Inspector General, the key attribute of any kind of an inventory is that it rotates and doesn't spoil for certain products. My understanding is the VA, has had emergency caches since after 9/11, which are basically small local inventory reserves. The Office of Inspector General audited these emergency caches and found widespread failures to rotate the inventories. This is a while back. What improvements has the VA made, and what can we expect to see in the regional readiness centers?
With respect to our report on the emergency caches, we had a number of recommendations, and one of them did focus on ensuring that they did not have outdated supplies in them. We've worked with VA on those recommendations so that they can improve them. We have another report coming out that should be out very shortly on how VA operated the emergency caches during the pandemic. And again, we found issues. A lot of them relate to communications, and I think it'll be an important report when it is issued. So with respect to the readiness centers, obviously we haven't looked at them because they're just starting here. But I think there are important lessons that can be learned from our emergency cache reports in terms of having appropriate leadership, having controls in place, and ensuring there's good communications among the various stakeholders so they know exactly what is expected of them, what the processes are, and that they fulfill all the requirements.
My understanding is the 2018 report or audit noted that an emergency cache had never actually been used to respond to a natural disaster or an attack. If that's the case, what's the purpose now, and were they dipped into during COVID or over the last year with the pandemic?
That's going to be in the report. I think some of them were dipped into, to use your phrase, and there are issues with who had the authority to do so. So again, we have a communications issue. I think emergency caches have a role. They can really be used, but you're right, they need to be appropriately utilized.
Yeah. And then, Ms. Kramer, how are the regional readiness centers going to rotate the inventories more effectively moving forward?
Well, that's one of the reasons that we want to be able to use the warfighter. But I want to distinguish between a regional readiness center and a cache. A cache sits inside a hospital, and it's for emergency response immediate where there's no time to do anything. They contain nerve agent antidotes. right? So you've got to be able to break that thing open immediately if you've got a chemical attack and need those kind of things. So I really want to keep those separate. That is very much at the facility. They're very small. I know that for COVID, there were some swabs for nasal swabbing removed at 7 VA medical centers, and 1 VA medical center removed some hand sanitizer. But because of the increase in demand to support almost universal PPE use in hospitals, the caches are not designed to support that kind of thing, a huge increase, and then for a protracted length of time. Here we are a year in.
Will DIMLs provide visibility into those caches, where they are, what's stored there? Will it get?
One of the other benefits of DIMLs is that it will do what the DoD calls set, kit, and outfit management. So we can actually manage a particular cache and be actually monitoring so that we can actually pull material out of there before it goes bad. That we would actually welcome the opportunity to use DIMLs for that kind of management of the caches.
Okay. Thank you, Mr. Chairman. I have no further questions and yield back.
Oh, terrific. I have no further questions either, and I don't see any other committee members here. Ranking Member Mann, would you like to give any closing comments?
I just really appreciate everybody's time. You know, when you think about Veterans Affairs, it's really important that at the end of the day, we are here to make sure that veterans are getting, the services that they need, and a good supply chain is a part of that. And maybe, it's not what people automatically think of when they think of VA, but it's the behind the scenes that has to be done and done well, and I think done better, to make sure that every facility is equipped to meet the needs of veterans when they show up. So I think it's a really important topic. It's sort of the structural bones, if you will, of parts of the system. And I just am grateful and commend you, Mr. Chairman, for having this hearing today.
Well, thank you, and I appreciate your comments, and I want to thank all of our witnesses for joining us here today. Especially want to thank our VA witnesses and the team behind them at VA that has really done extraordinary work over these last many months. Truly heroic efforts to make sure that our VA facilities are supplied, that people are safe, and that we're able to meet the needs under these really extraordinary circumstances. Of course, I think we've identified again today the fact that we have antiquated systems in place that need improving. We need to see innovation happen over time. I think we've identified a number of ways that we need to see progress as we move forward, and I look forward to continuing to work with all of our witnesses to see that achieved. We clearly need to institute that comprehensive supply chain management strategy. And so we'll look forward to more detail on that. Once again, I just want to thank everyone for their participation. I think our subcommittee is going to continue to closely monitor these programs in the months and years ahead. And I think we want to continue to see progress. We want to build on what's been put in place over the last few months. And I think by working together with VA, with the majority and minority on this committee and subcommittee, that we can achieve some additional progress for the future. So I think our discussion today really strongly supports the need for that War Stopper program that we talked about. I'm excited to hear about the interest that is still there, and I look forward to working with VA in terms of the legislative angle on that. And I hope that we can continue to communicate about additional ways that we can support the transformations that are necessary to reinforce VA's supply chain. So with that, I just want to thank all of our witnesses once again here today for all of your testimony and all of your work. I really appreciate the briefings that we have been receiving already on these topics, and I look forward to more detail in the future. So with that, once again, I just want to thank everyone for being a part of this hearing today. And unless there's anything else, all members of the subcommittee will have 5 legislative days to revise and send remarks and include any extraneous materials, and the hearing is now adjourned. Thank you all again, folks. We really appreciate it.